A very warm welcome to everyone joining us from different parts of the world. We are delighted to have you with us for today's webinar titled Unpacking the Packaged Ultra-Processed Foods and Your Heart. So I'll start by briefly setting the context for today's discussion. We know that India's healthscape has been shifting rapidly, and that makes today's topic even more relevant than ever. While we continue to address the burden of communicable diseases, the growing challenge of non-communicable diseases demands urgent attention. According to WHO 2022 estimates, India accounts for 2/3 of all NCD-related deaths in the Southeast Asia region. And despite proactive efforts by the government, shifting dietary patterns and rising consumption of ultra-processed foods continues to worsen the NCD burden. While traditionally most dietary discussions have focused on malnutrition, their role in driving NCDs is now widely recognized. In fact, the recent Global Burden of Disease study identified poor dietary habits, including high salt, trans fats, and processed food intake as key risk factors for NCD mortality in India. So, to strengthen the focus on this important issue and drive strategic action, the Harvard T.H. Chan School of Public Health India Research Center is launching a webinar series, The Impact of Diets on Non-Communicable Diseases, Evidence and the Next Steps. This series will convene national and global experts to discuss the evidence, identify gaps, and share strategies to strengthen public health responses in India. Today's session marks the inaugural event in this series, and we are truly honored to be joined by an esteemed panel who will share their insights on how we can tackle this epidemic. My name is Swati Bakshi, and I serve as the Deputy Director of the Harvard T.H. Chan School of Public Health India Research Center. Established in 2015, our center is the first global center of the Harvard Chan School, working to advance health in India and globally through research, training and capacity building, and knowledge translation and communication. Our center is led by Dr. K. Vishwanath, Lee Kum Kee Professor of Health Communication at Harvard T.H. Chan School of Public Health. This webinar is co-hosted along with Anuvaad Solutions, led by Dr. Ananya Avasthi. Anuvaad is an accelerator for knowledge translation designed to translate the latest scientific evidence into actionable policy insights for advancing India's nutrition agenda. And now it's my absolute privilege to introduce our distinguished, highly respected and accomplished panelists. Firstly, Dr. Avinash Sunthlia. So he's joining us today in place of Dr. Swasti Charan, who is unable to attend due to a last-minute meeting at the ministry. So Dr. Sunthlia serves as the Deputy Assistant Director General at Directorate General of Health Services under the Ministry of Health and Family Welfare, Government of India. He's a public health professional with more than 11 years of experience working across various levels of the health system in India. He has been involved with various national health programs, including the Tobacco Control Program, Non-Communicable Diseases, Climate Change and Human Health, Integrated Disease Surveillance Program, Healthcare of Elderly, to name a few. Welcome, sir. It's a pleasure to have you with us today. Next, we have Dr. Frank Hu. Dr. Hu is the Fredrick J. Stair Professor of Nutrition and Epidemiology and Chair of the Department of Nutrition at the Harvard T.H. Chan School of Public Health. He also serves as Professor of Medicine at Harvard Medical School and Brigham and Women's Hospital. His major research interests include epidemiology and prevention of cardiometabolic diseases through diet and lifestyle, gene-environment interactions, and risk of obesity and type 2 diabetes, nutritional metabolomics, and many more. Dr. Hu serves as Director of Dietary Biomarker Development Center and co-director of Obesity Epidemiology and Prevention Program at Harvard. Welcome, Dr. Hu. We are delighted to have you today. Next, I would like to welcome Dr. Yutaro Sitoya. Dr. Sitoya is a team lead for NCDs and comorbidities at WHO India Country Office. Specializing in public health, he has over 20 years of experience in health research and health system development. Before moving to India, he served as country liaison officer at the WHO Tonga office, supporting the government of Tonga, and held roles at WHO Division of Pacific Technical Support in Fiji and the Department of Mental Health and Substance Abuse at WHO headquarters. Welcome, Dr. Sitoya. We are so glad to have you join us. Last, but certainly not the least, Dr. Meenakshi Sharma. Dr. Sharma is Scientist G at the Indian Council of Medical Research, leading work on cardiovascular diseases and neurosciences. Her research focuses on hypertension, ST elevated myocardial infarction called STEMI, and stroke. She spearheaded the India Hypertension Control Initiative, which was a nationwide primary healthcare intervention and has now been integrated into India's national program for NCDs. She has also played a key role in developing STEMI and stroke care models for rural and remote settings, with the STEMI model now incorporated into national program guidelines and adopted by several states. Welcome, Dr. Sharma. It's a pleasure to have you with us. This was only a brief glimpse into the remarkable work and achievements of our esteemed panelists. Each of them brings a distinguished record and wealth of experience, and I could not possibly do full justice to their contribution in such a short introduction. I'm sure they will share more about their work during this discussion. Today's session will be moderated by Dr. Cindy Liang. She is an assistant professor of public health nutrition at the Harvard T.H. Chan School of Public Health. Trained as a nutrition epidemiologist, her research broadly focuses on diet-related health disparities in structurally marginalized populations. Thank you, Dr. Liang, for joining us today. So the flow is like this. The panel discussion will run for about 40 minutes, followed by 10 minutes for audience questions, and then closing remarks by Dr. Ananya Awasthi. I encourage all attendees to please post their questions in the Q&A box. Our team at the back end will collect these questions, and they will assist Dr. Liang in the discussion. With that, I'm pleased to hand it over to Dr. Liang to lead today's discussion. Over to you, Dr. Liang.
Thank you, Swati. And hello, everyone. I'm pleased to be the moderator for today's webinar. In the time that we find ourselves in right now as a Harvard community, I think this webinar really highlights the power of our global community, particularly as we find our common passions in promoting healthy food systems for all. So today's webinar is called Unpacking the Packaged, Ultra-Processed Foods in Your Heart. Now, given the ubiquity of ultra-processed foods, I think that we have all seen, purchased, and probably consumed ultra-processed foods at some time in our life. So this is really an issue that affects all of us and our families and our communities. In the past 10 to 15 years, there's been an avalanche of research really demonstrating the potential health effects of consuming too much ultra-processed foods. So I'm really excited to start the conversation with our esteemed panelists today. We're going to be ambitious and cover a lot of important topics, including the prevalence and scale of non-communicable diseases, the cardiovascular effects of ultra-processed foods, enhancing public health awareness of these products, and also best practices and evidence-based strategies for promoting healthy diets and cardiovascular disease outcomes in India. So as Swati said, if you have questions that come up in the next 40 minutes or so, please add them to the Q&A button at the bottom of your Zoom box. We will be compiling these questions, and then we'll be able to ask them during the Q&A session in the last 10 minutes. So with that, I will start the questions with you, Dr. Sunthlia. India has a rising burden of cardiovascular disease, particularly in the younger population. So what policy measures and regulatory strategies are currently in place to address these dietary risk factors?
Yeah, greetings to the esteemed panelists and the audience who have joined in for this particular webinar. And I shall like to start from the 19th April Liver Days theme, wherein we had this uh, food is medicine as the, I would say, as the slogan or the quote which was popularized across. And of course, our webinar also, when we say unpacking the package and we talk about the harmful effects of processed food, ultra processed food, of course, and we also consider them as syn goods along with salt and sugar. So of course, it is, I would say, the need of the hour to raise awareness among the younger population regarding the harmful effects which the ultra processed foods have in the world, wherein there is a lot of advertising also, and social media, and of course by means of yeah, movies or TVs or whatever, television, they are trying to popularize that. So a whole lot of measures are necessary. And I think basically your question primarily focuses on the policy measures and regulatory strategies. Of course, but the policy measures and regulatory strategies, they are both, our regulatory strategies are both in terms of strengthening the monitoring and evaluation component, and at the same time, I would use the word supportive supervision, wherein we find out the faults wherein in the system, and then we try to rectify them. And of course, our policy basically it focuses on the raising awareness on the harmful effects of ultra processed food. First, secondly, discouraging it, targeting the younger population to adopt healthy lifestyles, and how they can through by means of behavior change, they can adopt it as a part of their lifestyle, so that they don't end up with cardiovascular diseases, or I would use the word NCDs for that matter. Because apart from tobacco and alcohol, unhealthy diet is one of the major risk factors, as whatever research studies have been conducted here in India. So unhealthy diet is one of the biggest risk factors which contributes to NCDs. So, and that could be to the tune of 20 to 25% of the cases are attributed to an unhealthy diet. So, we need to have it. So, if through the whole of society approach or whole of government approach, and a robust intersectoral coordination, we have the ecosystem wherein we promote we encourage health promotion and behavior change, and discourage the consumption of foods that are rich in fat, sugar, salt, of course. We have certain movements or flagship programs such as Eat Right India movement is there, wherein we promote, just to cite an example, that the traditional foods which used to be there in the households, of course, India is a very primitive civilization. Over the years, there have been a lot of food habits which have continued over the years. So maybe they should stick to that. Then, with respect to the behavior change communication, we have the Fit India movement, wherein we promote the health promotion activities, the marathon or yoga activities, particularly in the younger population. Our target is that when I talk about the, of course, the early detection and screening component I have mentioned, which we do it at something known as Ayushman Arogya Mandir or Health and Wellness Center. So there are some centers which are there at the 5,000 population. For every 5,000, we have one wellness center. So the community health officer, his main role is to promote and help the population adapt to health promotion measures and physical activities and all that. If I have to specifically mention, of course, there is no need to mention that we have a regulatory body. Of course, every country has it. We do also have it with the name of food. FSSAI, the name as FSSAI, and there is a ban on industrial trans fats and development of front of pack labeling. Everything is there, and school and youth focused policies are there. And with the setting approach, we also try to target the schools, the colleges, and we call it as healthy campus. The name what we have given is that healthy campus or setting approach, wherein we encourage taking healthy food. So eat right campus, that is something. All this is there. That is, yeah, a whole lot of initiatives.
Wonderful. Thank you. Thank you for that very comprehensive response. It's really helpful to hear about the whole society, whole population approach, but then to see all the ways and all the age groups that are being targeted by these prevention efforts. Let me move now to Dr. Hu. Dr. Hu, can you tell us a little bit more about what ultra-processed foods are, what categories of ultra-processed foods might be more harmful for human health, and how do they influence metabolic pathways related to cardiovascular disease?
Hey, thank you, Cindy, and good morning, good afternoon, good evening, everyone. It's truly a pleasure and a privilege to participate in this panel discussion about ultra-processed foods. I think this is a very timely topic, very important topic. As we all know, cardiovascular disease is the leading cause of deaths in India and responsible for nearly 1/3 of total deaths. And also, CVD is increasing both urban and rural areas, and heart disease tend to occur in younger populations in India compared to Western populations. And we also note that India is considered as a capital of type 2 diabetes. Almost 100 million people in India are living with diabetes. And another major trend is increase in obesity, especially abdominal obesity in both urban and rural areas in India. So in terms of diet, we know that poor diet is now a leading cause of deaths globally and surpassing tobacco smoking. And ultra-processed foods has received tremendous amount of attention in the past 10 to 15 years because of increasing research on the harmful effects of UPFs. So I'm going to spend a few minutes just to present our recent studies on ultra-processed foods and the risk of cardiovascular disease. Let me share my screen. Can you see it?
Yes, we can see your screen.
Okay, yeah. So the work I'm going to present was conducted by a former student, PhD student in our department, Kenny Mondaza. He was working with me and another faculty member in our department, Juicy Matai. So his entire thesis was focused on UPFs, type 2 diabetes, and cardiovascular disease. So today I'm going to present one of his thesis papers focused on cardiovascular disease. So this paper was recently published in one of the Lancet journals. So this study was conducted in our three large cohort studies: the cell study 2, and the health professional follow-up study. So typically, UPFs are classified based on the LOVA framework. So this framework has been widely used to classify food products based on the extent of processing applied to them. So according to this framework, there are 4 categories of foods: unprocessed or minimally processed food, like apples, pears, and other fruits and vegetables, milk, and then the second category is the processed culinary ingredients like butter, vegetable oil, or table sugar. And then the third category is processed foods. And the fourth one is ultra-processed food, or UPFs. So ultra-processed foods has received most attention because those are the foods, industrially produced foods, which are very high in unhealthy ingredients such as added sugar, sodium, and unhealthy fats, and also numerous additives and other ingredients. And the consumption of UPFs has increased dramatically worldwide. In the US, more than 2/3 of the calories consumed by the US population, especially by US children, come from UPFs. And so in this study, Kenny specifically analyzed the associations between UPF consumption and the risk of CVD, including coronary heart disease and stroke in cohort studies. And then he conducted a systematic review and meta-analysis to update the evidence on the associations of UPFs with those outcomes. So those are the three large ongoing cohorts still being conducted at Harvard School of Public Health and the Brigham Women's Hospital. So the Nurses Health Study, Nurses Health Study 2, and Health Professional Follow-up Study. So with the three cohorts combined, we have almost 200,000 participants who have been followed for several decades. Dietary information has been collected using validated food frequency questionnaires every 4 years. So the repeated measures of diet has been very useful in terms of reducing measurement errors and also representing long-term dietary habits. There are multiple categories of UPFs. So here we have 10 different categories: highly processed bread, cereals, sauces, spreads, sweet snacks, desserts, savory snacks, sugary beverages, and processed meats, yogurt, ready-to-eat meals, hard liquor, and artificially sweetened beverages. So the outcomes include incident CVD during the follow-up. We have non-fatal MI, fatal CHD, and non-fatal and fatal stroke, and total CVD. And then the analysis was conducted using Cox regression model adjusted for a wide range of cardiovascular risk factors. And then the meta-analysis, systematic review, was conducted following the PRISMA guidelines. And here, the mean intake of UPFs in our cohort is somewhat lower than in the general population. So we have about 30 to 40% of calories come from UPFs. And then UPF consumption is associated with increased energy intake, decreased diet quality, and increased prevalence of obesity. And those are the main results for CVD. So as you can see that in the pooled analysis of our three cohorts, higher consumption of total UPFs is associated with significant and elevated risk of total CVD, CHD, but not stroke. So comparing the highest quintile with the lowest quintile, there is 11% increased CVD risk and a 16% increased CHD risk. And then when we look at specific categories of UPFs, the results are quite heterogeneous. So for some of the UPF categories, for example, sugary beverages, processed meats, there is a clear, significant positive association between higher consumption of those foods and the increased CVD risk. However, for other categories, such as breakfast cereals, especially cold cereals, and whole wheat bread, and also yogurt, there is a moderate inverse association between high consumption of those foods and the risk of CVD. So clearly, not all UPFs are created equal, and the associations between the UPFs and the CVD depend on different categories. And then this meta-analysis included 22 prospective cohort studies, which include the results from the three cohorts that I just mentioned. And as you can see that overall, there is a significant positive association between UPF consumption and the CVD. So the highest comparing the highest category with the lowest category, there is a 17% increased CVD risk. And this association was statistically significant. And this is also true for CHD, about 23% increased risk. For stroke, the association was lower. It's about 9% increased risk. So overall, there is a significant positive association between total UPF consumption and the risk of increased risk of CVD. However, UPF subgroups presented divergent associations. So clearly, the worst type of UPFs, soft drinks and animal-based products, especially processed meats. However, some categories of UPFs, such as whole wheat bread, cold breakfast cereals, yogurt, dairy dessert, and some alcohol beverages, actually associated with lower risk of CVD. So I think the take-home message is that UPF as an overall category is certainly detrimental for cardiovascular health, but I think it's important to keep in mind that the UPF categories are very heterogeneous in terms of the different type of foods and also and their potential health effects. So I think that's all I want to present, and let me pass this to Cindy.
Thank you, Dr. Hu. I think that's a really important message for us to keep in mind as we're continuing to go through today's webinar, that not all UPFs are created equal. Some of them are obviously worse for health, as Kenny's data has showed us, and some are actually, not as bad as we might have initially thought. And it also shows there's so many different products that go into this categorization of ultra processed foods. It's not necessarily, the really brightly packaged foods with the characters that you see on the billboards. It really encompasses a lot, and it's important to be able to tease out which of these foods are actually most harmful for cardiovascular disease. So let me move now to Dr. Satoya. Dr. Satoya, based on global evidence, what are some effective population-level strategies that have successfully reduced ultra-processed food consumption in other countries? And can you take some of these strategies and contextualize them for India?
Yeah, thank you. Thank you, Cindy, for the question. And thank you very much for the organizers, the Harvard School of Public Health India Research Center, for organizing this important webinar. As Dr. Frank mentioned, I think it came in a very good timing because India is facing a lot of increase in NCDs. Obesity is increasing. Also, household income has increased, so many people have access to unhealthy foods. Urbanization is happening. So we know that more than 70% of Indian people in India actually die from non-communicable disease. So it is becoming a big issue. And as Dr. Avinash summarized, there's a lot of things already happening in India. And the WHO has been supporting, but there is a few things we could think about in terms of reducing the unhealthy diet. I think, I've been in India for the past 2 years, and I understand India is a big country. It's like a continent. So each state is like a country in itself. So it's, so we need to make sure that there's one single intervention will not work. We need to make sure that we come together and have a multifaceted approach. And also in these 2 years, I came to know that there's so many already good practices within India at a small scale. So as WHO, we are trying to support the Ministry of Health and Family Welfare to scale up those interventions. But when doing that, it is important to make sure that these are, as a public health specialist, as a public health organization, we need to make sure that those interventions are, there's so many good interventions, but it needs to make sure that these are cost effective and has maximum impact. So for that, WHO has been there's so many WHO guidelines. Some people say there's too many. But if I say one document we should think about is what we call a best buy document. We have for a document called Tackling NCDs, Best Buy and Other Recommended Intervention for Prevention and Control of NCDs. So list evidence about how we could, approach these different issues in the NCDs, and list the most cost-effective best buys based on the literature and evidence. So in that we have a number of global, recommendations from WHO. But of course, we need to make sure that these recommendation to be, contextualized in India, and actually many of these best buys already is happening in India. But if you're introducing new things, it's important to make sure that it's contextualized to the cultural situation in India. We need to make sure that we do some background search about the data and the data gaps to make sure that it's most important issue to tackle. And also, most importantly, we need to make sure that we consult all stakeholders and make sure there's some pilots and testing, especially for communication materials, behavior changing communication materials. It's not in India, and it's in a different area in tobacco. But I always talk about this example about targeted or culturally adapted approach. When I was working in India WHO office, we were introducing pack warning for tobacco, and we were testing some images of the tobacco. And one of the images was the black lung, the lung which became black. And we showed to Tongan people and asked about what their impression about this photo. And they said they thought it was actually a chicken, it was a charcoal chicken, which they thought it looked delicious. So it's important that we, don't take it granted that this image will fit everything, and this communication will make sense to every culture. We need to make sure that there's testing is happening. And also, that's the most important thing, is to make sure that it's enforced. If we make a policy or plan or a law or taxation, we need to make sure that it is enforced and also make sure that it's monitored. So there should be a good monitoring mechanism so that we can evaluate the regulation tax if it's working or not. And to make sure if it's not working, we can adjust to make sure that's implemented in the Indian context. So as a summary, there's a number of recommendations from WHO, including front of package and nutritional labeling, restriction of marketing, taxation for unhealthy diets, subsidizing good healthy diets, elimination of trans fat, etc. But yeah, it needs to be adapted to Indian context. And of course, India has been doing a lot, and WHO is happy to support in any way. Thank you very much.
Thank you, Dr. Satoya. I think that's really helpful to just hear about the array of strategies that are in the WHO toolkit for how to improve diet quality and to prevent NCDs. And also just that lessons that we learn from other public health campaigns, like with reducing tobacco consumption, we could adopt for improving diet quality as well. So let me move on to Dr. Sharma. Hey, Dr. Sharma, can you walk us through how the Indian Council of Medical Research is contributing to national research on dietary risk factors, particularly in the realm of ultra-processed foods? And are there any insights that you can share about the dietary trends in the Indian population?
So good evening, Dr. Cindy and Swati. So I'm thankful to you for inviting me to this very important panel discussion. Why this is important? The simple reason, I have been into research for the last 30 years. So when I did my PhD in biochemistry from PGI Chandigarh, I worked on atherosclerosis. I will share with you that I'm the person who has witnessed the transition So during my PhD thesis, I remember writing the first line that this is not the disease of Indians. The heart diseases belong to the Western countries. Then in 2002, I joined ICMR. I was given cardiology as one of the area to look after. And suddenly I saw that we are at the top. So that was the first thing which I noticed. And I said, what has happened in these 10 years? And just in 10 years, how can we move from a disease which was not there in a country to a disease to be on the top of that disease in the entire world? And I think the reasons may be because there were so many things which were happening at the economic sector. We were changing, our policies were changing, we were becoming much more free. Free trade was there. And by 2019, when we have the global burden of disease report, then we have 60% of the disease burden, which is being attributed to NCDs now. And out of that, the maximum is to cardiovascular diseases. 17% of our deaths are because of heart attacks. So incidentally, I was in Andhra Pradesh day before yesterday, and I visited a district hospital. And we are running a STAMI program for the first time over there, where the district hospital and the community health centers, they have started providing tenecteplase, a thrombolytic drug, so that the reperfusion can be done quickly and the patient's lives can be saved. What was touching there was that there was a fellow who was 24 years old. And he came to home at around 5 o'clock in the evening. Suddenly he had a severe chest pain. Now, because he recognized the symptoms, he said, I recognize the symptoms within 3 or 4 months. He rushed to the district hospital and the drug was available over there. So the drug was injected. He had a massive heart attack. 24-year-old having a massive heart attack. So with the angiogram was clear because the heart attack had been aborted. He had actually come within a window period of 1 hour. But then that really focuses on what is happening in our youth, because we are seeing these cases more often now. So at ICMR, if you look at our ICMR, our National Institute of Nutrition, that is the one which works on dietary research. We have an entire institute for that. And this institute has given us a figure of that 56.4% of the disease burden, NCD burden, this can be attributed to the diet which we are taking. So that's worrisome. So if we are able to make changes in our diet, I think half of our burden, or 70 or 80% of our burden, will be gone. The National Family Health Survey 5, it really showed that our adults are 25% of our adults are obese. 12% of our adults are have blood pressure. Have diabetes, blood pressure, and around 30%, every third person has a blood pressure. But what about the children? The children are also not now lagging behind. That's worrisome. That's something which is really worrisome. So we found that our institute conducted a comprehensive national nutritional survey in 2019, where they observed that 34% of the children in the age group of 5 to 9 years, they had elevated triglycerides. And around 10% of them, they had pre-diabetes. That's really worrying. 7% of them had the creatinine levels high. So with that kind of population, that what is happening over there? The NIN said that because they are consuming more of ultra-processed foods. So that is one of the reasons that they are having so much of risk factors for heart diseases in them. If you look at the EAT Lancet Commission report, then it recommends that 2,500 kilocalories per capita per day. But in our case, we are not even consuming that much amount of calories. Our calories are around 2,000, which are much lesser as compared to the Western diets. Whether it's urban or the rural areas, that's the amount which we are consuming. Except for the 5% of the population which is rich and is consuming much more, the others are consuming that levels. So where are we going wrong? Our cereal intake is around 97% in rural areas. Out of the entire energy expenditure, we are getting 97% of our energy from the cereals. And we are consuming that much amount of cereals in the rural population above the recommended levels. And in urbans, it's around 70%. Then the UPFs, they comprise around 11% of the energy per day in urban areas. And even in the rural areas, it's around 4%. So the NIN also did a survey in which they found that the cereals, they contribute to 50 to 70% of the energy, whereas the pulses, they are 6 to 9% of the energy. So based on this data, they came up with my plate for the day. They said that you are consuming too much of calories from wrong categories of food. So you need to understand that what is the amount which is required in each category of the food group. They divided the foods into 8 groups, and then they have advised that 45% of the total energy should come from the cereals now, instead of the 50 or 70% which we are consuming. Then pulses, eggs and meat, 14 to 15%, and fat to 30%. Another nuts, seeds, and milk to 8 to 10%. So there is nowhere they are mentioning that we should be taking ultra-processed foods. So that is the thing which they have told now. Then they regularly come up with dietary guidelines, and these guidelines we started formulating before our independence in 1944. But what we were doing till now was we were giving the recommended dietary allowances. We have come up with another guidelines in 2024. For the first time, the guidelines are mentioning that we have to restrict salt intake, use oils and fat in moderation, do proper exercise, minimize sugar and ultra-processed foods. I think these guidelines are very, very important for the country because they take into account the changing scenario. So we are moving from a country which was deficient in foods. I remember the 70s when we did not have even food to feed our people and had to get food from US, the wheat from US to feed our people. So now we are food rich. That's not an issue. But what we are eating, that has changed. So these guidelines are important because they give us message how to handle the food safely, choose minimally processed foods. They talk about the importance of food labels and physical activity. They are also talking about swapping of high-calorie foods with healthier foods. But again, I have a question in mind, whether the guidelines will change our dietary habits. Guidelines normally do not change the dietary habits. They normally fail to change the dietary habits. It's not only because people are not aware of these guidelines. It's not, nutrition is not really very easy to change. A small thing like salt, you will not change because somebody else is telling you to eat less salt. The taste becomes very important. So what is required is community awareness activities, but much more which is required is nutrition education. So do we have plans for that nutrition education? And nutrition education does not has to be done in a routine fashion. Not teaching, but for example, we have the ANECT course. So can we use that course, which is a practical approach to nutrition education, where the students, they practice what they have learned. So they discuss among themselves that what works and what doesn't work, why it doesn't work. So those kind of things which have been taken up by African countries, other countries. I think they have to be put into place in our systems too. We will require some the education material and the techniques for teaching them. They have to be unique to this country. So we will have to look at the output indicators, whether they are working or not working. Thank you very much.
Thank you. And those were some very sobering statistics that you shared about just the prevalence of poor diet quality and some of its subsequent consequences, including high BMI, hypertension, and diabetes. I wanted to come back to a question that you raised, and I actually want to pose it back to our panelists, Dr. Sunthlia, Dr. Satoya, Dr. Hu. What do you think the value is, or how important do you think nutrition education is for reducing population level UPF consumption?
Cindy, can I start?
Please.
Okay, yeah, I agree. I think education is definitely very important in terms of increasing awareness about the harmful effects of UPFs, and also teaching individuals about how to read food labels, the ingredient list, and how to identify unhealthy UPFs. So I think those are very important in terms of individual behavior changes. However, I think behavior changes are not sufficient in terms of dealing with this toxic, obesogenic food environment we are facing now. And so that's why we need policy solutions to improve our food environment. So I think we can learn a lot from several Latin American countries. I think they have done really incredible job in terms of improving their food environment by using front-of-pack warning labels, by restricting marketing of unhealthy food to children, and also through taxation of sugary beverages and other unhealthy food. One of the best examples, of course, is Chile. So Chile introduced the black and white warning labels in 2016, and that led to a significant reduction in sugary beverage purchases by more than 20%. And there was a restricted marketing of unhealthy foods to children, and they actually banned marketing some of the very unhealthy UPFs to children, including cartoon characters, packaged foods, and TV ads during children's programming. Another successful story is soda tax. So both Chile and Mexico implemented soda tax several years ago. I think Mexico has already achieved a significant reduction in soda purchase after introducing the soda tax in 2014. So soda purchase dropped by more than 5% in year one, and more than 12% by year two. So again, those policy strategies, I think, are very important in terms of improving the overall food environment in the communities, in the societies, and combined with individual behavior changes through education and through increasing awareness about the harmful effects of UPFs. I think this kind of combinations can have much greater effects than just individual behavior changes alone.
Dr. Sharma, did you want to respond to Dr. Hu?
A very quick response to Dr. Frank. Dr. Frank, thanks for raising the issue of front labels. But as far as India is concerned, we have only 10% of the foods which are packaged foods.
Mm-hmm.
We have a whole range of unregulated sector, foods in the unregulated sector. So front label packing will remove some of the things, I think it's only an advertisement in our country that something has to be done for the unregulated sector too. But that is what I'm looking forward from your side, that your suggestions rather. It's a very different situation as compared to the Western countries where we have more of homemade foods. For example, when you said the definition of the UPFs is industrially produced foods, then I was thinking that for India, it should be foods which are prepared for commercial purpose.
Yeah,
So
that's certainly a very good point.
Yeah.
And the packaged food, of course, predominant in Western population countries, and is now increasing dramatically in low and middle income countries. But homemade, commercially prepared foods are also, I mean, many of them are also very harmful. So the question is how to identify, I mean, harmful UPFs, even homemade harmful UPFs. Again, I think, yeah, combination of education, increasing awareness, and also, I mean, having cooking skills to prepare meals from scratch using fresh ingredients and whole foods. I think those are all important strategies to reduce the consumption of harmful UPFs.
Dr. Satoya?
Thanks. Just quickly on this discussion, I think, yes, I think I agree with Dr. Meenakshi that only the dietary guideline will not change people's behavior. It is important to do, awareness raising or behavior changing campaign. That's one of the recommendations in WHO's Best Buy document. So make sure we do a targeted messaging to, the population, which is high risk, but also we need to do it at the settings approach, including at the schools, so targeting children to make sure that they have good knowledge when they're growing up. Also, of course, many Indian people may not eat processed food, but of course, when taxing the unhealthy foods, it will, and reducing the tax for healthy food, it will impact the household consumption as well. So that area India is doing, but maybe you can think about increasing the tax or decreasing the tax for healthy foods. Thank you.
And then finally, Dr. Sunthlia, I saw that you had unmuted briefly. Would you like to share any thoughts as we start to close up today's webinar?
Yeah, of course. Dr. Utaro has already added quite a few points, and we closely work with WHO India for augmenting the capacities at the community level and, of course, spreading the awareness. Yes, the issue of ultra-processed foods and food prepared at home is there. But with respect to licensing, we are also strengthening the vendor licensing for the unregulated sector, so that whoever is preparing those foods, they should have that license to prepare the food. And one of the requirements of the license is that they are educated about the kind of food what they are preparing, and of course the harmful effects due to ultra processed food. Secondly, with respect to which we closely do with the WHO, and of course the guidelines are also there, and the Healthy Campus initiative, which we are taking with the health promotion team in WHO, wherein we touch upon the campuses across schools and colleges. We are strengthening that part. So accessing food which is available at the unregulated sector, or for that matter packaged food as well, because India is a multifaceted society, and of course whatever policies they are useful in one part of the country, they may not be useful in another part. There is variation across geographies and rural urban area. So every 100 kilometers we have to change the policy, the way we deal with the issue. So there has to be intersectoral collaboration, teamwork. We need to with the research team, we need to work upon the gaps which are there in the system, and of course strengthen the institutional framework. Yes, we have at the policy level multi-sectoral. We have something known as the National Multi-Sectoral Action Plan as a part of interministerial coordination, wherein all the 47 ministries, and to be specific, if we narrow down to 20 ministries which are directly or indirectly associated with the production or taxation or other things related to the same goods, which also includes the ultra processed food. So we have that mechanism in place, and of course we regularly try to improvise and strengthen it. And we have something which is known as the National Nutrition Strategy, wherein we touch upon every kind of food, be it the regulated or the unregulated sector. And yes, of course, one of the key factors, which I'll just keep it short, we are already running out of time. One of the key factors is behavior change. So food consumption habit is something which is more or less to do with the behavior change, the kind of food which the people eat. So that, of course, it needs sort of regular engagement with the audience, and if we start young, it is better. So of course, all the policy level things, or programmatic level things, institutional level thing, community level, whatever mechanisms are in place, yes, we need to continuously strengthen it. It is part of a process always, and whatever gaps and things are there, as a team, we try to overcome. Yeah, that's all.
Thank you so much, Dr. Sunthlia. Now I am going to turn it over to Dr. Ananya Awasthi. She's the founder and director of Anuvaad Solutions, who's the co-host of today's webinar. I'm going to leave it to her to share some closing remarks.
Thank you so much for such a lovely discussion, and I can really feel the pain of all the attendees who've joined, who must have a lot of questions in their mind. But I think all I'd like to say is that this is a very, very important topic, and being a public health researcher from India, we do see that increasingly, at least in the past 5 years, increasingly there's a lot of policy traction about diets and its impact on nutrition. Parents, caregivers, wherever you go, people are coming forward and asking you, oh, we did not know that ultra processed foods and junk foods can be so unhealthy. So definitely there's a lot of demand for such an information, both with the policymakers as well as people around, because as mentioned, curriculum on nutrition or any evidence-based platform that can provide information the way it's been translated today is something that really needs to be built upon. And I really hope that this webinar is one of the many one of the many initiatives that the Harvard Center and even Anuvaad, and of course the entire community, public health community in India and at Harvard, will continue to take. And I think this topic definitely, I mean, this is just the beginning and not the end. And we look forward to collaborating on more such pieces. But one can definitely see that the agenda setting for ultra-processed foods, HFSS foods, both on the policy side as well as with the common population, there's definitely a lot of demand for this subject. And it's clearly evident with all the questions that people still continue to post on the chat box.
Thank you, Dr. Awasthi. And yes, there are pages and pages of questions that I would have liked to ask all of our panelists if we had much more time. But obviously, this is an issue that we are all very interested in, and hopefully we'll continue to make movement on it at a global scale. So just to wrap up, I wanted to thank the organizers for today's webinar, all the attendees for being such wonderful audience members, and of course, our esteemed panelists for the thoughtful discussion. Thank you, everyone.
Thank you.